He's joined.
Hi, Vish sir.
Hello, sir.
We are live, please.
Good evening, sir.
We are live.
A very good evening, everyone, and thanks for logging into this very important webinar from the Maharashtra Ophthalmic Society and Vidarbha Ophthalmic Society. Now, as we all know, cataract surgery today isn't just about removal of the cataracts and implanting an IOL. It's also about giving patient a lot of satisfaction in regards to the quality of vision and spectacle independence. Now, with that regard, it's very important for all of us to know about management of astigmatism and how to generally go about it. And to take note of that and teach us more about it, we have an excellent webinar planned today, which will be moderated by Dr. Anand Pimparkar and Dr. Bhagyashree Deshmukh. Now, with this background, I will like to invite our president, Dr. Shirish Thorat, to please introduce our speakers and carry forward the program.
Thank you, Vish sir. On behalf of MOS and VOS, I welcome you all to this important webinar. Let me thank all the speakers for sparing their valuable time for this event. Actually, we started planning this webinar 3 days back only, and I'm grateful to all speakers that they agreed to be a part of it in a short time. All the speakers are not only prolific surgeons of their area, but they have also developed their own ways to tackle astigmatism during surgery. Today's moderator, Dr. Bhagyashree Deshmukh from Amravati and Dr. Anand Pimparkar from Sambhajinagar are eminent corneal surgeons of Maharashtra, and I'm thankful to them for accepting the invite. And I'm sure this webinar will be a great academic feast for everyone. Thank you, and over to you, Bhagyashree.
Yes. Good evening, everyone. And what's truly remarkable about today's webinar, I guess. Yeah, can you hear me?
Yeah.
Yes, sir.
Good evening, everyone. What is truly remarkable about today's webinar, in my opinion, is that all our speakers have personally developed some innovative gadgets for toric IOL planning. And today we'll get to hear them firsthand about their experiences, about their insights, and their new innovations. So without further ado, we will just get started. And our first speaker is Dr. Vaishal Kenia. He is a prolific cataract and refractive surgeon with 27 years of private practice in Mumbai. And he will be giving us, talking about how he treats his astigmatism in cataract patients. Over to you, Dr. Kenia.
Thank you so much. I'll just share my presentation. Can you see it?
Yes. You can see.
Yeah. 1 second. The presentation. So, can you hear me loud? Yeah.
Yes.
Yeah. Okay. So how do I treat astigmatism in my cataract practice? So 30% of patients with cataract have an astigmatism of more than 1 diopter, and every incision on the cornea adds on to this astigmatism, and we need to know to tackle this astigmatism very well. Otherwise, it compromises the visual outcome. With the days of premium IOLs where we are dwelling into not only monofocal lenses as well as the presbyopic correcting lenses, all lenses require the astigmatism to be corrected. We need to collapse the Sturm's conoid, because if we do not collapse this Sturm's conoid, the contrast loss is there and the vision becomes very, very fuzzy. Definitely astigmatism, keeping a residual astigmatism definitely helps in the depth of focus. But with presbyopic correcting lenses, if we keep astigmatism, residual astigmatism more than 0.75, then it would interfere with the near vision. So it's very, very pertinent to completely collapse if possible, the Sturm's conoid. For every 1 degree toric IOL misalignment, there is an effective reduction of astigmatism correction by 3.3%. So that is why it is very, very important. How do we master? And in today's talk, there are different ways to, bell the cat. Each one will dwell how and what is the best way. So it is up to the audience to decide what is the best way to do. In my practice, I have usually astigmatism more than 0.75 is what I treat. And if it is against the rule, I treat it more aggressively because astigmatism against the rule progresses with age. So even posterior corneal astigmatism importance we have understood, because just treating the anterior segment corneal astigmatism can give you surprises and surprise residual astigmatism. So what can go wrong in treating astigmatism? So first and foremost, most important is measuring the correct data. I'll come into the details of it, how and what. And then once you have measured this data well, how do you execute to perfection? Because you have done the measurements properly, but you do not execute it well, then also it can have flaws. And most of the post-operative toric lenses can rotate in the first 1 hour. So most of the rotations, if we can avoid, and if they rotate, what to do, that we will talk. So before capturing any readings on any machine, the most important thing is the posture of the patient. And once the head is placed well, which is not tilted, because tilting of the head, I will show, has an effect. It can induce cylinders. It can induce an asymmetric bow tie. So patient not moving during the eye test. What we typically do is, before we start measuring an optical biometer, we ascertain that the light passes on both the sides through the lateral canthus on the same side, so that we know that the alignment of the head is straight. The Myers should be clean and sharp before capturing. If the Myers are also distorted, we know that the patient has some ocular surface problem and which needs to be treated. Never put any lubricating drops once you have seen a Myers are dull or not sharp, because that can give you a false reading. Natural blinking is what is advocated and should be done. So head tilt during measurement can lead to axis errors in topography and keratometry reading. So it's very, very important. Even if you have a very high-end optical biometer, but if your head posture is not proper, everything will be collected or captured will be wrong. So it's very, very important that our basics are in place. The head posture, the alignment is important. This is just an example. A subtle head posture can induce changes in the astigmatism. A minus 0.55 diopter becomes minus 0.72 just because of a vertical anterior posterior head tilt or a lateral head tilt. Both can cause induced astigmatisms. So it's very, very important before you measure the head posture, the sitting posture of the patient is ascertained that it is proper. Now make sure the Myers are clear and sharp, because whatever data you capture, but the Myers, you can see astigmatism of just minus 0.55 was shown as minus 1.26 cylinder. So you're correcting a wrong astigmatism as you have captured wrong. So garbage in and garbage out. So it's very, very important before we talk about hi-fi tools or any other machine. The most basic things have to be in place. That is capturing the right data, and the head posture of the patient is that important. So most of the places today with the use of screen usage, the dry eye or meibomian gland dysfunction is very, very common. So if you feel, in my hands, the eye light therapy works like magic. within no time, within a couple of days, the patient's tear film is back to normal. But if you don't have highlight therapy, you can put them on lubricating drops, and it would take some more time depending on the severity of the dryness. But irrespective of the severity of dryness, the light therapy works like magic. Hot spots and irregularly shaped placido discs. It's very important that any toric case, you do at least a topography, if not a tomography. Definitely a tomography would score over a good topography. And corroborate your readings with multiple tools. I know the K values captured by different tools are at different millimeters from the center of the cornea, but you can correlate. You can have an autorefractometer and your keratometer also to corroborate, just to ascertain that the quantum of astigmatism on all the keratometers is the same. Irrespective of the K values, the quantum of the astigmatism would be the same on all keratometers. And for looking at the axis, the topography is very, very important, or the tomography. So at my place, I use at least 2 to 3 devices to capture the K values. But the final K values are taken from the IOL Master 700 and fed it into the Virion. So the IOL Master 700 has got certain features which are very, very important.
Critical details that can lead to unsatisfactory results if not identified. Avoid refractive surprises caused.
See, unlike the other optical biometers, the IOL Master 700 gives you whether you're capturing it through the fovea, and also the small macular cube tells you about the macular quality. So any optical biometer today scores over the ultrasound biometer for sure. And there are many reasons into it. I'm not dwelling into it. But the most important today is whether the TK value is important or the anterior K value. So in special situations only, I take the TK value, that is post-refractive, post-corneal astigmatism, and irregular corneas, but like keratoconic corneas. Otherwise, I do not take the TK value. Otherwise, I just rely on the anterior K value. So this is where the topography comes in. You have measured a toricity, but whether it is an asymmetric or a regular bow tie is very, very important. If it's an asymmetric bow tie, then you may have to tell the patient that the quantum of astigmatism may not totally be corrected because there is a component of coma which is present. And this is about the anterior astigmatism. Suppose you do a tomography. I have a lot of cases, and we have presented where only there is a posterior corneal curvature which is steep, which is a subclinical keratoconus. So you can miss that if you are just doing a topography. So it's very, very important to do a tomography. Even the anterior posterior ratio has to be kept in mind. So I use the Holiday EKR, which is very, very important in all the cases. It gives me this, it shows a bifid spike, which tells me that this is a regular astigmatism and we can implant a toric lens. But here is a case where you can see that the K values are spread across, and this is very irregular cornea. In such a case, I had done a PRK, and then after PRK treated, this is the regularization of the cornea, and then we went on to doing a cataract surgery. So post-operatively, if you have a irregular cornea, PRK or LASIK, whatever, this is
Swapnil sir, please mute yourself. Swapnil sir, please.
This is a case where there is a posterior corneal astigmatism. And these are the cases which can be missed if you just do a topography. So this is where we had presented using the Barrett true K keratoconic formulas were used, or Kane keratoconic formulas here were used for the posterior keratoconus. So requirement for a good toric IOL surgery requires a good image captured, good planning, and perfect planning with cyclotorsion and eyeball tilt compensation, and definitely a proper intraoperative IOL alignment and stability. So a Virion today helps us in a high volume practice to do all these activities in a better way and a faster way without any transcription errors. So different manual marking tools were used, and today we have my fellow speakers speaking on digital toric apps, and here also I have used and compared Swapnil's Precision Toric app, Dr. Saurabh's iToric marking app, and the Toric Cam, and we compared it with the Virion. And believe me, these are very good apps and they worked very well. We are shortly publishing the data about that, and we found that these apps can be a good substitute if we do not have Virion. So Virion digital marking system, the measurements are taken from 0.8 to 1.2 millimeters, and the axis is measurement from the central 2.8 millimeters. So once the measurements are done, the most important part of the Virion is the planning, and that is where it scores over the other markers. It is not just the planning of the amount of astigmatism, but even where you are going to, plan your visual axis centered, or whether it's going to limbal base centered, or it's going to be pupil base centered. So that's very, very important, where you are marking the center of the visual axis. That's most important. I know Dr. Ashish Sakpal is going to speak more on that, but this is a very important point where there is a significant angle alpha. It will definitely have an effect. Yeah, definitely these are subtle small points, even if the angle kappa is significant, then it will definitely have a effect. But marking on the visual axis is very, very important, because in the Virion, there is a fixating red light right in the center. And once the concentric mires of the topographer of the Virion falls on the cornea, it takes the image from the center of those concentric circles and then marks the visual axis. So it's a very good way of marking the visual axis. And not only that, it also helps you to plan and calculate your IOL power also. So this is a very good tool. If you have a high volume practice, this helps you in a big way. It helps you to customize your surgical induced astigmatism. My surgical induced astigmatism for the right eye is different than the left eye. That is in my hands. Though it may be a subtle difference, but definitely that customization helps. Whether it's a temporal incision, whether it's a superior incision, whether it is a superior temporal incision, all that data is refined as soon as and continuously by the Virion. So this is the case where an astigmatism of 3.3 diopters at 100, what to plan. Now Virion helps you whether the LRI would work or whether a toric IOL will work. It helps you to find out the best, what is the best. At my place, I use the LRIs and the AK, the femto AK now for any astigmatism less than 1, because there is almost over a period of time, there is regression, and I feel the best way to tackle astigmatism today is definitely with a toric IOL, and if it's more than 0.75 diopters, I definitely toric IOLs would be the best bet rather than relying on these relaxing incisions. So the Virion not only helps you in capturing the image well, there are no transcripting errors. It compensates for the cyclorotation. It accounts for the surgical induced astigmatism. then helps you to during intraoperatively for a proper capsular axis on the visual axis. It helps you for positioning the IOL also. And after that, once your data is fed in, it optimizes your SIA continuously. So definitely it's a good way and a good tool. And now Virion has been upgraded to Argus. Now Argus is more available and it has got the same features. Plus it's an optical biometer. So this is most important. The Virion planner helps to plan the incision locations also properly. So where the astigmatism can be maximally be neutralized, I can vary my incision also. So whether it's at 180 or at 135 degrees, this pre-operatively I can plan. So I'll skip about the centroid vector just now. I'll talk more about the toric IOL power calculations. So at my place, not only good measurements of the K values is important on different machines, but I also use different kind of IOL power calculators. Like, for example, the Kane formula is a AI based formula. The Evo is a thin lens formula and a Barrett is a thick lens formula. So I use all the three calculators and then extrapolate data from them and find out which and how do they correlate. And this has helped me to hit the target very well. So not only correlating the K value measurements, but also the IOL power calculator correlation is also important.
Vaishal sir, can you sum up the...
Sure. Last few slides, I'll sum up. So nowadays I use the astigmatism, I use the Castrops normogram for AK. So to collapse the Stump's conoid, measure correctly, calculate correctly, execute correctly. Thank you. I'll stop sharing 1 second.
Thank you. Thank you very much, Dr. Kenia, for the wonderful talk.
Yeah. 1 second. I'm not finding the cursor to stop sharing.
Vaishal sir wonderfully explained everything, where you can, what are the pitfalls of calculating toric IOLs and how do you avoid them. So taking good readings, I think most of us depend on optometrists or other staff, technical staff. So there we have to do good training and make sure periodically we should check whether they are following the protocol properly or not. Just like simple head tilt can cause a not such a desirable or good outcome, it can turn into an average outcome. So nice talk, Dr. Vaishal sir. Congratulations to you. Next
Thank
topic.
you. Thank you so much.
Bhagyashree madam, next topic.
Yeah. So our next speaker is Dr. Swapnil Kothari. He is the director of Parshva Netralaya from Jalgaon. He's an accomplished cataract and cornea surgeon. He has been a very good friend since PG days, Shankar Netralaya, and recently has developed precision toric system for toric IOL planning. And I myself have been using this for almost 2 years now. So this is what he'll be talking to us about. Over to you, Dr. Swapnil.
Yeah, sorry. Good evening, everyone. I'll start my slide sharing. Is this slideshow visible?
Yes, visible.
Yes, it's visible.
Yeah. So as Dr. Vaishal was saying, there are basically 3 apps. I'm going to concentrate on the app part of the toric IOL procedure, since many of our colleagues might not have access to a live system similar to Virion or Callisto. Then you can always fall back on smartphone apps to help you out. today's most of the smartphones have inbuilt gyroscope and inbuilt accelerometers, which actually helps to kind of take away the pain of accurate marking. The most important, as Dr. Vaishal has correctly said, the most important part when you are doing a toric IOL surgery is measurement, then planning, and then execution. So this really, the app part really comes into the execution part. Measurement, you are dependent on whatever machines you have. Even the autorefractometers give a quite good amount of accuracy when you're talking about regular corneas. Then planning, since most of these apps are, most of the formulas are available online, the planning part can be done properly if you are meticulous enough. Kane formula, Barrett's toric formula, and Evo formula, all three are there online available. So you can use any of them and combination actually to get the planning part done for you. And when it comes to execution, that's where the apps and Virion and Callisto come into play. So,
Gishi, am I audible?
Yes.
Okay. So I sorry for connecting late. I was little tied up in OT. So my talk is about TORIC app, but it's a quite old app now. I think it was uploaded on Google Play in 2013 or 14. And I've been using it for almost 10 years. And after that, after I shifted to markerless system, of course, there are many studies done now. There is a recent meta-analysis of smart app in ophthalmology, and it was rated as the #1 app for the toric alignment. I will share the screen. Is the screen visible?
व्यवहारिक माणूस चालते हुशार आणि व्यवहारिक हे जेव्हा दोन्ही मिक्स होते लय खतरनाक.
Hello.
It's visible, sir. Can you just make it full screen?
Yeah, I will just. I'll be showing a couple of videos. The first video will be showing how the app is used, and when compared to the markerless system, which is the gold standard in the sense that it's automatic alignment, how does it work? So here is the first video.
Systems which I have used for the toric IOL alignment so far. Callisto Eye by Zeiss is the markerless alignment system where the patient's eye data is collected by IOLmaster 700, scleral image is taken, and then using Callisto Eye, the surgeon can see it through the surgical microscope, and the external digital injection system will give you that data while you are operating. While iToric Patwardhan is a free Android app, you can find it on the Play Store. So this is how the iToric app is used. You can use any method of manual marking of your choice. You can use bubble marking, you can use slit line marking. This is what I do. I do freehand marking approximately at 180 degree, that is 180 degrees apart, and then I use the iToric app. Once it opens up, it's just like any other camera app that we have. So we use it in portrait mode. We can use the torch, and you can use autofocus mode. You can zoom in and out while you are taking the image. To make sure that patient's head posture is correct, on the app you can check that both the eyes are at the same level using those markings that you can see in this app. Once the head posture is proper, we take the snap of the patient's eye by zooming in on the patient's eye. Once you have a satisfactory photo, then you fit the cornea in the outer circle and center the pupil in that circle. Once that is done, you press the protractor button on right bottom of the screen. 2 red dots will appear and you align them on the blue marks that you have created on the limbus. Once this is done, all the data is there with us, and you enter the intended axis of toric IOL placement which you have calculated by your toric calculator, and once that is entered, you find that the gyroscope in the mobile corrects for any error in the reference mark, and then it will give you the corrected axis of placement. So here, for example, 173 was the IOL axis which was intended, but because there was error in the reference axis marking which was corrected by TORIC, the new axis is 169 degrees. So that is something you have to mark on table intraoperatively using the Mendes ring. Now let's look at a case where we'll see the two approaches, how they work. So I have clicked the patient's photograph after freehand manual marking, and you can see that 103 is the axis of placement for IOL, and because of the error in the marking, the new axis of placement is 107 degrees. So that is something I want to mark intraoperatively. This is how the Callisto Eye registration takes place. It's quite quick, and the Callisto Eye data receiver will register the conjunctival vessel and match it with the IOL master data, and you can see immediately it will show the axis of placement. If you compare the green line which shows the 180 degree axis, it is slightly different from the manual marks, so which obviously has been corrected further using the TORIC. So here intraoperatively I am going to use the Mendes ring. I am just highlighting those horizontal marks which are already created manually, and then I am going to mark 107 degrees here as per the TORIC. So as you know that the manual gauges like the Mendes gauge, they do not have very accurate markings. They are usually 10 degrees apart, so you have to basically think between 100 and 110 degrees and towards the 110 degrees, so to get the 107 degree axis. But if you compare the manual marks versus the TORIC, they are quite close, and the error is within plus minus 5 degrees as you see in this case. Callisto Eye additionally gives the incision assistant and CCC assistant to have a proper size capsular axis, if possible centered over the visual axis. Now coming to the IOL alignment, you can see the Callisto Eye will give real-time IOL axis. So that is the axis at which I want to place the IOL, and you have to see to it that they lie on the same line as far as possible, if not within these 3 lines. You can have 1, 3 or 5 lines, and this is the manual marks, and what I do differently here is that I have to align those according to those marks you can see on the cornea, and though they are not exactly aligned, they are quite parallel to these corneal marks, and this difference is because of the angle alpha, because when we do the manual marking we do not take that into consideration. So there is slight difference between the corneal axis and the IOL axis, but if they are parallel, that is fair enough, we get good refractive results. So this is how the two fare. The IOL is exactly placed same way in both, and you can see in Callisto Eye the marks are according to the Zeiss align system, while in manual marking there is some difference, that is because of the angle alpha, but both IOLs are placed as per the calculated IOL axis. So in TORIC assisted manual marking, it has corrected for the error in the reference marking. So if you compare the two, the Callisto Eye assisted system, there are no manual errors and better patient comfort and workflow. There is reduced intraoperative time because we don't have to again mark the axis, and it also corrects for the head position errors during the measurement of the IOL, that is biometry. This is very important, and that your technician should understand how to do the biometry correctly. Otherwise, of course, Callisto Eye will correct for those errors. It also corrects for angle alpha, may be more useful for trifocals and EDOF. Now when we consider TORIC Patwardhan app assisted manual marking, the manual errors definitely are reduced, but intraoperative marking is still necessary. There is definitely better patient comfort and workflow as compared to slit lamp marking or bubble marker marking if freehand marking is used. But the technician should be trained to avoid head position errors while doing the biometry, as well as taking the snap using the TORIC app. Now looking at the cost effectiveness, it definitely improves the accuracy, but Callisto Eye has a high cost involved, and it is cost effective only for high volume toric IL use. So I would definitely recommend it for high volume practice, as it minimizes the manual errors which are going to increase if you have high volume practice. It definitely improves surgeons' comfort, reduces the intraoperative time, and also the attention needed is less. iToric Android app has zero additional cost. It's a free of charge Android application. It improves accuracy of manual marking by correcting the reference marks. So it has immense advantage. If you are using manual marking method, it will definitely improve the accuracy of your outcomes. So all in all, both are good. Clinically, I think both are comparable, though of course Callisto Eye will improve the accuracy in tough cases where the patients are uncooperative, and the manual marking errors such as intraoperative marking definitely reduces with the Callisto Eye system. So for more such videos,
Thank
do
you. So
subscribe.
that was first video, and I will just brush upon another video where we can use the same app for other applications of the app as well. And this is the published article by Dr. Zain Khatib using the iToric app, and with just simple marking pen and Android mobile, we can have a very good workflow and very accurate axis marking. There are other applications of this iToric app as well. One such use is for slit lamp calibration. So even if you are using slit lamp for marking, how do you know that your slit lamp is exactly giving you 180 degree? So you can use the iToric app to check that. This is another very interesting use that I found, that instead of marking the cornea, we can take a retroillumination image of the patient's eye using the infrared imaging of autorefractometer, and then we can mark the opacities. And I found it quite useful, particularly in patients which are not that cooperative. And even for post-operative checking of the toric IL axis, you can see that I have taken an infrared image using the iToric app, and I can exactly see the axis of placement of the IOL. It is very accurate by using this to the degree of 1 degree. And the retroillumination image marking which I showed, I used it very well in this particular young patient where I wanted to implant a toric IL because patient had very high astigmatism of almost 4.5 diopters, and patient was not very cooperative for the marking. I don't have a markerless system, so what I did is that I took a retroillumination image. Patient was cooperative for autorefractometer, and then I marked these opacities using these red dots. So that became my reference axis, and on table I marked the same opacities for the reference. So that becomes my reference axis. As you can see here, I am marking according to the iToric app picture, and because I wanted to place the IOL at 108 degree, what it shows is that I have to place the IOL 25 degrees counterclockwise from the reference axis marks. So that is my final axis of placement. And I found that this was very useful, because in post-operative period when I checked the child with after the IOL placement, I found that the IOL was lying exactly at the position where I wanted it to be. So on table, after marking, it is just like routine toric IOL surgery. This is the IOL which I have placed as per the marks. You can also see the posterior capsulotomy which I have done because he is a 4-year-old child, and the toric IOL appears very well placed. And this is a post-operative picture. You can see the IOL is nicely placed at 111 degree, just within 3 degrees of the intended axis, which is a great outcome. Thank you so much for watching, and do use this iToric. Okay, thank you. So those were a few points which I use. Of course, now iToric app is available on iOS also. So those who are using Apple phones, they can also use the same app.
Thank you, Dr. Saurav, and thank you for joining in spite of your busy schedule. And it was a wonderful talk, and you clearly illustrated the importance of using the free app for toric IOL marking, and it's quite comparable to the expensive systems like Callisto or Verion. Thank you so much. Now I would like to invite our President, Dr. Thorat sir, for concluding remarks. Thorat sir.
Sir, he is not responding.
I think Thorat sir is on mute.
Yes.
Hello, Thorat sir.
Thorat
Kiri
sir.
sir. Hello.
I just call him. I think sir is busy with some patient or something.
Okay.
Not able to join right now. I thank all the speakers for giving wonderful talks about the toric IOLs, and it will help all of us in improving the patient care and improving outcomes in cataract surgery, particularly in patients with astigmatism. Thank you very much.
I would also like to thank our moderators, Dr. Anand Pimparkar sir and Dr. Bhagyashree Deshmukh.